It is my honor now to present our next presenter, which would be the president of the Egyptian Society of the Glaucoma, Professor Ahmad Khalil, which will present to us the very, very important topic of neovascular glaucoma. So, Professor Khalil, please take the floor.
Thank you very much, dear Nader, and I repeat that we cannot but thank Keith for his very precious time given to us today and your excellent moderation. We enjoyed every bit of his talk, actually, and his wonderful lecture, and the nice discussions and answers. So thank you again and again, Keith, for being with us today. And now, actually, I go to maybe a simpler talk about the neovascular glaucoma, and it is my target is to make things simpler. We have so many modes to talk about neovascular glaucoma. We have modern modalities to go ahead: the diode cyclophotocoagulation, the micropulsed laser, the repeated anti-VEGF injections, which is flourishing everywhere, I think, in the world, the tubes and implants. But actually, my talk would be beyond this. We start with the rubiosus iridis, which is iris neovascularization, and angle closure glaucoma are serious complications of a number of diseases affecting the eye. Pathologic intraocular neovascularization can be potentially blinding if not detected and treated promptly. So it was actually first described in the 19th century and was described, if some of the older guys here remember, we remember the old name of hemorrhagic glaucoma. So it is retinal ischemia and hypoxia that triggers a pre-angiogenic cascade, and then neovessel growth, no endothelial tight junctions, and increased permeability of these pathological neovessels, and then inflammatory response and fibrous membrane ensues, resulting in the glaucoma. We have main causes for the neovascular glaucoma, which is mainly the proliferative diabetic retinopathy, the central retinal vein occlusion, and the ocular ischemic syndrome. And I'd like to mention that worldwide, the first two are recognized as actually almost 50% of the cases of neovascular glaucoma, and the less diagnosed ocular ischemic syndrome accounts for almost 50%. What we see here in Cairo and in the Middle East, probably, I mean, most of the cases, at least which present as diagnosed as neovascular glaucoma, probably the first two count for more than 70 or 80%. So the proliferative diabetic retinopathy, they have iris neovascularization 1 to 10% among all diabetics in various works and papers. 64% among patients with PDR, and then neovascular glaucoma and diabetes mellitus is 2%. So this is a big number if you know the actual number of the diabetics in the world. And the 21% of PDR where the frequency can be as high as 65% with more advanced forms. So neovascular glaucoma may occur due to the ischemia. Before neovascularization of the retina or optic disc are present, you find a apparently normal fundus, but with neovascular glaucoma. This can actually quite happen. And then we move to the central retinal vein occlusion. It is 1/3 of the central retinal vein occlusions cases are ischemic at presentation. And if we remember the name of the 100 days glaucoma, now called the 90 days glaucoma, regardless of the number of the days since the start of the vein occlusion till the formation of the neovascular glaucoma. And the larger the area of the capillary non-perfusion, the greater the risk for developing NVG. The ocular ischemic syndrome has not to be forgotten, most likely to be missed or misdiagnosed, and may present with low IOP in the beginning despite the presence of neovascularization, and this is caused by the decreased perfusion of the ciliary body. But then in these cases, prompt diagnosis and treatment can save not only the eye, but also the patient's life. So the eye here acts as a window, like in many diseases, to the actual well-being of the patient himself. So early diagnosis, this is an often missed entity in its early stages. Remember the cases you have seen. diagnose maybe more cases with vigorous and severe neovascularization rather than with a tiny vessel. And you have to suspect the early cases if you see a unilateral glaucoma case in a diabetic. If you see one diabetic patient and then he has a high IOP of 30s or 40s or even less than 30s, but then the other eye is perfectly normal, you have to suspect neovascular glaucoma. And in many of these cases, actually, when I examine thoroughly, I miss the rubiosis in the beginning, but now I find that there's discrepancy between both eyes. And when I search thoroughly, I find the solitary or couple of tiny neovessels either in the periphery of the angle or crossing the angle. And by the way, if we see sometimes what we call physiological blood vessels in the iris, but these physiological blood vessels, they never cross the angle. So if we see any blood vessel, micro blood vessel passing through the angle, then this is a neovessel. And then if visual acuity is reduced in an otherwise clear eye with no advanced cupping, then this is a high possibility of central retinal vein occlusion. Treatment principles: we need to reduce the elevated IOP. This is our target as glaucomatologists. And then treat the underlying disease that led to this ischemic insult. Maybe if I just choose one slide for the treatment of neovascular glaucoma, it will be this slide. This is the first treatment to be given to our neovascular glaucoma patients and often missed in our practices everywhere. Topical corticosteroids and cycloplegics, atropine or cycloplegic eye drops. These are of utmost importance that cannot be underestimated. And then we have to do PRP. And when do we do PRP? Now. The first thing to do, because if you can do PRP today, you might not be able to do it tomorrow. So you have to do it as early as possible. It can stabilize the IOP in actually several incidences where I received 40s or 50s IOP and then prompt steroids and cycloplegics and PRP. Actually, even with less anti-glaucoma treatment, the IOP could lower in many instances. So we have to do it as soon as possible and as generous or aggressive as possible. Of course, anti-VEGF have to be considered, and definitely they should be tried in all cases when we are able to. Some cases, PRP might not be possible, and then pan-retinal cryotherapy with the periotomy in first to make retinal ablation should be taken out. The pharmacological treatment, first thing, we have to avoid anticholinergic. Though pilocarpine is very rare and not available in many locations, in Egypt at least, and probably in the Middle East, but sometimes doctors and patients come to it, and in many cases come to me, they are having pilocarpine treatment. So this is, as you might expect, should be absolutely contraindicated in neovascular glaucoma cases. Then beta blockers, topical carbonic anhydrase inhibitors and alpha agonists should be tried. The role of prostaglandins is always query, and as with uveitic glaucoma, actually it should not be tried in the first line as a first line or in the beginning, never. But sometimes, and in some instances, it can be tried by caution or with caution when others are not enough. And then you watch the response, particularly of the prostaglandins, when you have all pre-treatment installed before that. So we talk about the surgery. Many cases with neovascular glaucoma remain refractory to pharmacological treatment. We all acknowledge that and require surgical intervention. If early diagnosis or prophylactic treatment with PRP is delayed, there is no general consensus regarding the best surgical approach. So again, we are in a dilemma, which is the best surgery? Probably trabeculectomy with mitomycin or antifibrotic agents will remain the standard for these cases. Limited success, yes, it is associated with the intraoperative bleeding. So, I mean, this surgery or other surgeries actually should be taken well after stabilization of the neovascularization with steroids, cycloplegics, and anti-glaucoma measures, and PRP, and then we can encroach on the surgery. The progression of the fibrovascular membrane actually post-operatively makes this surgery of limited success. But if we are able to control the NVIs by immediate PRP and anti-VEGF, probably we can have a chance. And in one research, 30% in 5 years with the use of fluorouracil, which is now replaced by mitomycin at the time of trabeculectomy, it was in 1995. So, and again, cyclophotocoagulation seems promising, and many of us have tried this and very promising, but then again, please, this is not a first step in the management of neovascular glaucoma. The aqueous drainage implants, the Ahmad or the Bayoumi or others can be tried, but again, all these surgeries are of not always with the great success we wish or we expect. Again, cyclophotocoagulation, I think, would remain for some years to come a good surgery to perform. To conclude, neovascular glaucoma remains a therapeutic challenge. Early detection is of utmost importance, and prophylactic treatment with PRP should be carried out as soon as possible and to be directed at the ischemic retina. These are key elements in preventing the visually devastating outcome of this disease. Thank you very much.
Okay. Dr. Ahmad, Professor Khalil, thank you very, very much for this very, very informative and interesting topic about this very, very important and really devastating disease, neovascular glaucoma. If you would allow me a question, please, sir, how long would you wait after control of the acute inflammation? Now, we all know that NVG sometimes presents with an acute inflammatory appearance of the eye, an acutely inflamed red eye, for which the patient must receive cycloplegics and steroids. Let's say, what is the time limit that you would wait after control of this inflammation, or you would not wait at all before going for surgery for these eyes, sir? Because the IOP is frequently, as you've pointed out, sir, very, very much elevated. So is there an approximate time limit, or you operate immediately? Approximately, I mean, roughly.
Actually, we cannot give a certain time by the number of days, but probably at least I would wait actually for a few weeks at least for the start of the action of the PRP and the medical treatment. Probably in a month or so I can do some interference. I mean, when after doing everything, including the PRP and the anti-VEGF injections. Okay, but again, a few weeks at least, not less than a month for sure.
Okay, and do we follow? There's no definite time. And do we follow the same rule as in uveitis, is that we manage the glaucoma, of course, much more important than the cataract. We deal with the pressure, of course, as first, and then you might handle the cataract later on. That's not a big issue.
Definitely is. Definitely is. Not only not a big issue, but I think also it is acting as a barrier for some time before doing. I mean, this is a classic teaching, but the lens would probably act as a barrier for some time. So we deal the glaucoma first, and then we do the lens later.
Sure. Okay. There's a question we have on the floor, sir, about micropulse lasers in this type of glaucoma. So we know that the literature is still very deficient in this issue specifically. You know, the studies are actually coming from Egypt. 2 studies so far published, they actually come from Egypt. But do we have any practical experience so far, or we still are waiting for the results?
I don't. And actually with some discussions from colleagues, international colleagues, they tell me it is not as strong or as effective as the regular diode cyclophotocoagulation we are performing. But I have no personal experience.
Sure. Okay. So there's another question, sir, about if we see that small tuft of blood vessels that are present at the pupillary border, and the gonioscopy still shows an open angle. First question would be: would this be a warning sign if the IOP was normal, was within the statistical normal? Second question would be: if the IOP was not within the statistical normal, the eye is still in the, let's say, the open angle stage of NVG. So would we again go for our stepladder approach of doing PRP and then doing the surgery, or we do PRP and wait? I mean, is that tuft of blood vessels at the pupillary border with an open angle any indicator or clue to wait or to operate earlier on the other hand, or there's any comment about that? That's
I think yes, this is what we are calling for of early diagnosis. And then if I definitely see this tuft of blood vessels or this definite neovascularization in a diabetic, I would definitely go for quick PRP and probably anti-VEGF, and then watch very carefully for the glaucoma. And if the new vessels increase, I find it still progressing, I will go for the medical treatment, steroids, cycloplegics, etc. But this, again, to my thinking, this should be treated as, yes, an impending neovascular glaucoma.
Sure, sir. Okay, now let's finish with one question from the attendees. It's a rather technical issue, but it's important. When the peripheral retinal cryo is the job of the retina specialist, so it's not the question is not about the logistics of referring the patient to the retina specialist or not. My personal question is, the retina specialist, when they do it, sometimes they're not minded of the importance of the conjunctiva in filtering surgery. And I quote your teaching, sir, about what could be more important than the conjunctiva for a glaucoma surgery. So for this instance, just for the sake of preserving the conjunctiva for a future potentially filtering surgery, would you do the peripheral retinal cryo yourself because you know the importance of the conjunctiva and you will preserve it, or you would refer it to a colleague? So it's not a question about logistics of referral, it's the question about preserving the conjunctiva. And would that be possible?
What would you do, dear Dr. Nader? Probably we can do.
If I would do it, I would personally do it. I would not refer it because when I used to refer, they used to ruin the conjunctiva.
Yes, it is not very demanding technically, actually, and it is within the scope of our work, I believe.
Okay, and the PRP would be done, as you've mentioned, sir, generously. The maximum number of shots, and but we don't have a maximum number of shots for the
is fully treated. I mean, you fully filled with your PRP shots, typically maybe 1,200 or so. But I mean, there is no number as much as you feel the retinal background is well full, and actually even also treating the center and the mid-periphery, not only the...
Okay, so a generous PRP is the recommendation. Finally, sir, do you have a preference for the type of steroid to be used, loteprednol or prednisolone or rimisolone or whatever? I think this question comes from someone who is considering the effect of steroid in raising the IOP. I think that's the concern. That's why they're asking.
This is one important point, actually. Okay, the first part of the question is that I used to say any steroids and even use dexamethasone, etc., with success. But in recent years, I have come to prefer prednisolone. I find it very potent and at the same time not causing an issue of increasing the IOP. Okay, the use of steroids in glaucoma is very tricky because we keep telling our patients, our colleagues, this is not to be used with glaucoma, this is not to be used in the glaucoma, and then in certain entities like the neovascular glaucoma and the uveitic glaucoma, these are to be used. And this is no confusion about this. Not everybody is steroid responsive, and definitely those uveitics and those neovascular glaucoma, they do not show, I mean, even if they have some kind of steroid response, it is not big enough to be compared with the inflammation lowering effect and the IOP lowering effect. So again, yes, we advise in other instances to avoid steroids totally in glaucomatous patients, especially in the juvenile age group, but in other instances, it is the mainstay of treatment of glaucoma.
Okay.
Mainstay under treatment of glaucoma.
Suppression of inflammation here is superior to any possible potential side effect from the steroids. It's a must.
Yes,
potency is an issue here. Okay.
I believe so. Okay.
So, thank you very, very much, Professor Khalil, for this excellent presentation. Thank you very much for having the time to answer our questions. And we move on to our next section. I think our sponsor has something to tell us, or Orchidia.
Hello, doctor. Greetings from Orchidia Pharmaceutical. I hope you, your family, and all your beloved ones are safe and in good health. I'm going to talk about dry eye patient, especially who is associated with itching. Orchidia offers the integrated solution from Orca-P-Post, a Polyfresh Extra. Orca-P-Post is anti-aging and anti-allergic agent, which is not only has exceptional antihistamine effect, but also has a novel special mechanism as anti-aging agent by inhibiting nitric oxide secretion at nerve endings. The second arm of our solution is Polyfresh Extra, which is a unique combination that gives extra hydration effect and balancing the tear film osmotic pressure, in addition to the anti-inflammatory effect of glycerol. Thank you for your time.
Okay, we take this opportunity to thank our sponsor, Orchidea Farm. And now I have the honor and pleasure to introduce our next speaker, our dear Professor Dr. Tarek Eid from Tanta University, who is going to generously share with us his experience about glaucoma following vitreoretinal procedures. So, Professor Tarek, please take the lead. Thank you, sir.
Thank you, Dr. Nader. And I'd like to thank you very much and thank Dr. Ahmad Khalil for inviting me today for this session, the fifth glaucomatology session, which is actually a great idea, and getting glaucoma to all the colleagues and general staff. I'm sure this is a very, very good course, to extensive course for glaucoma for all the general ophthalmologists. I'm talking about a difficult type of glaucoma to manage, actually, which is the glaucoma that happens after interventions into the vitreoretinal. And usually the interventions that can happen in the vitreoretinal with the vitreoretinal surgeon can be either laser treatment, and the laser treatment includes PRP or vitreolysis, and also intravitreal injections with our anti-VEGF or corticosteroids, and the surgical management in the form of scleral buckling, barzoplantar vitrectomy, intravitreal gas, or silicone oil injections. So these are the common procedures that can be done by the vitreoretinal surgeon, and we are going to discuss the instance of IOP elevations and how to manage these cases. If we start with the common PRP or pan-retinal photocoagulation, which there is a transient rise of intraocular pressure after PRP, which can up to 90%, and this happens usually in the first few hours. And usually it is related to the amount of energy delivered to the eye. And usually it can be either open angle or closed angle. The open angle type is mainly due to impaired usual scleral outflow because of the ciliary body congestion, or maybe because of prostaglandin release. Another hypothesis is that it could be because of injury to the short ciliary nerves, and this will impair the ciliary muscle tone and the outflow facility. On the other hand, the closed angle glaucoma type is usually due to choroidal and ciliary body congestion, and this causes anterior rotation of the iris lens diaphragm, and in the meantime, pushing the angle forward and closing the angle. With the angle closure type, make sure that you are not going to use myotics, and usually this is not a pupillary block glaucoma, so PI is not helpful. How about the vitreolysis for vitreous floaters? This technique of YAG laser vitreolysis actually gaining more popularity because it's fast and non-incisional and somewhat inexpensive. And if you can imagine that about 33% of the populations can have visually impairing floaters, it means that this procedure can be done widely. But the problem with this procedure is that it can occur. Retinal tears and retinal detachment can happen, injury to the crystalline lens, or damage of the posterior capsule, also refractory open angle glaucoma. And we have a report of 3 cases with refractory open angle glaucoma that has to be managed surgically. And the mechanism is not well understood, but it says that could be due to obstruction of the trabecular meshwork by debris or floaters of the floaters or macrophages, or it can be from the shockwave damage to the trabecular endothelial cells by the laser itself. How about the injections inside the eye? We have either anti-VEGF injections or steroid injections. The anti-VEGF injections is now very, very common to be done with the retinal surgeons and usually used for the treatment of macular edema or choroidal neovascular membrane. And common anti-VEGFs that we are using in practice now are the Avastin, the Lucentis, the Eylea. So IOP rise can be either in the form of short term or long term with the anti-VEGF. The short term happens in almost up to 90% of cases, and the pressure can be up to 50 millimeter mercury. And this is actually due to a large volume is injected inside the vitreous cavity together with a high scleral rigidity. And usually it returns to normal in about 30 to 60 minutes. And what we can do to avoid this pressure spike, usually you can treat the patients with glaucoma medications, or you can do some ocular compressions by massage or ocular digital massage, and sometimes with some of the retinal surgeons do a paracentesis to release some aqueous outside the eye. How about the long-term rise? After anti-VEGF, this actually is not well understood. It can be defined as a patient who is normotensive before injection, and after injection, you measure the pressure and you find it above 20 millimeter mercury for 2 consecutive visits, or there is an increase of 5 millimeter mercury from baseline. And this happens in about 3 to 12% of patients, the non-glaucomatous populations. But in patients who are already glaucomatous, it can be as high as 30%. And the mechanism actually is not well understood and may be a multiplicity of factors that can work in this condition. What are the prophylactic measures that can we do to avoid this long-term rise of anti-VEGF? First, we have to monitor the intraocular pressure. We keep stressing on the retinal specialists. You do the injections, you look for the patient next day or after 1 week or after 1 month, and they never check the pressure. They just make sure that the edema decreased, the OCT, the thickness decreased, but they don't care about the pressure. These patients need to have a pressure measurement every visit. And proper storing and handling and preparation of the medications, especially now in our area, we now split the Lucentis and the Eylea, which are supposed to be single-dose units. We split them and handle them and store them so they can have some debris, and this can increase the pressure. And glaucomatous patients, we have to use a treat and extend regimen. It means that you don't do the injections regularly on specific intervals. No, you have to reduce the number of injections and try to extend the period in between in glaucoma patients so it can have the pressure back to normal. So these are the prophylactic measures that we need. How can we manage? Usually we manage like primary open-angle glaucoma patients. As we heard from Dr. Ahmed, we don't give prostaglandins as a first monotherapy treatment, but we can keep them at the end because we have these patients that have macular edema that can be potentiated. Steroid treatment, intravitreal steroids are actually also gaining popularity. We know from the literature that steroid responders in the normal populations are 65% low responders and only 5% high responders. While in the glaucoma patients, the reverse, actually 5% only are low responders and can be as high as up to 90% high responders. And usually steroids can be administered topically or periocular injections, intravitreal injections, or by systemic therapy. So what are the risk factors for steroid injections? Intraocular injections carries the highest risk. Primary open-angle glaucoma patients, high myopia, diabetes mellitus, history of connective tissue disorders, and traumatic angle recession. These are risk factors that these patients can be high responders to steroids. The mechanism of steroid-induced IOP rise usually resistance to outflow, and this resistance can be due to inhibition of enzymatic activity, changes in the microstructure of the trabecular meshwork, or even obstruction of the trabecular meshwork physically by the crystals, for example, of the triamcinolone acetonide. So if we now go specific to the intravitreal steroid therapy, we usually use it for non-infectious uveitis and for macular edema, especially with diabetes or CRVO. These are the common steroid injections that we can use. First, intravitreal triamcinolone acetonide, which is the Kinalog or the Kinacort. We have the dexamethasone intravitreal implants, the Ozurdex of allergen. And we have fluocinolone acetonide implants, and these are registered and Iluvin, and actually we don't have them in Egypt, but they are available outside. This table can show to us the differences between the four groups of steroids injected inside the vitreous cavity. And what's important for us is the duration of action. For the triamcinolone, it's about 2 to 4 weeks only. For dexamethasone, 3 to 6 months. For the retisert, it's 30 months. And for the Iluvin, about 3 years. And what happened? The IOP rise and the time to IOP rise. With the triamcinolone acetonide injections or with the quinacort injections, we have about 32 to 45% rise and start usually about 1 week and last for 9 months. With the Ozurdex, it starts after 6 weeks and lasts up to 6 months, and the percentage is low, about 15 to 30%. With the other two, actually the percentage is high, especially with the red shirt, it's about 60%, and can last for even a year. So these are the intravitreal steroids that we use, and the incidence or the prevalence of IOP rise with them. How can we treat this? Medical treatment like primary open-angle glaucoma, especially with the aqueous suppressants, we have to note that these steroids are injected intravitreally. So the option of discontinuing the steroids, like with topical medications, is not available here. Laser therapy sometimes can work, like the SLT. It can help to reduce the pressure, especially with the adjuvant therapy with the patients. But how about the patients with resistant IOP rise? If there is no response to maximum therapy, first if we have an implant inside the eye, then we can go and remove this implant, like the Ozurdex implant. Or if we have a suspension of triamcinolone acetonide and the pressure is intractable, we can do vitrectomy to remove the bulk of the suspension of the steroids. But if patients who have severe uveitis and need to have the continuous steroid treatment, in this case, we have to do filtering surgery and don't remove the steroids. And the filtering surgery or the drainage device can help to reduce the pressure. So this is the treatment with intravitreal steroid therapy. Comes the question, is it possible to know which patients will have a high intraocular pressure after intravitreal steroids so we can avoid? There was a study with topical dexamethasone provocative test before intravitreal triamcinolone injection and found that there is 100% positive predictive value, but only 60% negative predictive value. It means that the positive response is a strong predictor that this patient is going to have high pressure after injection of triamcinolone. But the negative response does not guarantee that he will not have this high pressure. The second question, how about glaucoma patients? Should glaucoma patients be injected with intravitreal steroids despite they have a very high response to the steroids? In fact, the companies for Ozurdex and Iluvin consider these patients not eligible for treatment. But if a patient who has resistant uveitis to treatment, conventional treatment, and you have to inject steroids, this can be done by some, but still off-label. So you cannot sue the companies. Now we go to the third part with the surgical interventions of vitreoretinal surgeries or procedures. The first one is the scleral buckling procedure. Usually we use scleral buckling for rhegmatogenous detachment. Glaucoma after scleral buckling is of the angle closure type and can occur in 2%. What are the risk factors for this? Either pre-existing narrow angles or the use of encircling band, and especially if we put the encircling band anterior to the equator, high myopic patients, and old age. These are all risk factors of getting high pressure after scleral buckling. The mechanism of glaucoma, as we mentioned, is angle closure glaucoma type. The point is that tight scleral buckle are very close to the vortex veins and can impair drainage through the vortex veins, which means subsequent congestion, swelling, and anterior rotation of the cellular body with forward displacement of the iris lens diaphragm and angle closure. These patients can be diagnosed by ultrasound or even UPM, and we treat these patients not like routine angle closure, pupillary block angle closure. We give these patients cycloplegics because we need to relax the cellular body and move it backward, and we need to give to them topical steroids so to lessen or minimize the inflammation and decrease the swelling of the cellular body. Equosuppressants are used. Try not to start with prostaglandins, and myotics are avoided completely. Usually these patients in the buccal, with treatment of the inflammations, the cellular body swelling decreases and the angle opens. But if patients are resistant, having high resistant intraocular pressure, we can do some laser treatment. This patient, as we said, it's not pupillary block, so we cannot do peripheral iridotomy. Argon laser iridoplasty may work if we are able to just contract the iris away from the angle, so it can decrease the pressure. But it can, the one that can work is either conventional diode cyclophotocoagulation, which decreases the intraocular pressure, and unfortunately it's unpredictable with a high rate of visual loss and even also high risk of hypotony. The non-conventional ones, which is a micropulse and the subcyclo or subliminal cyclophotocoagulations, actually have a high safety profile. There is low risk of hypotony, but the pressure may not be as, the reduction of the pressure may not be as much, and usually short lasting. This is a video for the micropulse diode laser, and we don't have this pop sound or the popping effect with the conventional micropulse, with the conventional diode laser. And we have this J-type probe. We do such journey on the inferior part and then superior part, and usually it delivers a subthreshold energy to the cellular body, exerting the effect. How about surgical interventions? What can we do? Can we do filtering surgery? Actually, it's not preferred. As we said, this is an angle closure glaucoma type. Everything is pushed forward. It may not be hard, may not be easy to do a trabeculectomy in these cases. Besides what we mentioned from Dr. Nader and Dr. Ahmad shortly about the conjunctiva with the scleral buckling procedure, extensive conjunctival and scleral scarring. So filtering surgery is not welcome here. Aqueous shunting devices are preferred because we put the implant remote away from the scarred conjunctiva, and also the implant, unfortunately the implant here and with the patient having a buccal and put an implant with it will do a crowding effect. How can you overcome this problem? Sometimes you can use a small sized implant or even modify the size of the implant. Sometimes you can use the permanent implant, you can cut it and reduce the size, so you don't have a crowding phenomena at the site of the buccal. And some also open the capsule around the buccal, and so include both the buccal and the implant in one capsule. And if some of you remember the Shocket procedure in the past, almost in the 80s, they use the tube. They use only the tube into the anterior chamber and insert the tube under the buccal and consider the buccal as an implant. So consider this as a aqueous shunting device. Glaucoma after barzillana vitrectomy, the second surgical intervention by the vitreoretinal surgeon to do a barzillana vitrectomy. And barzillana vitrectomy is done for almost many retinal disorders, BDR, BVR, retinal membrane, detachment, macular hole. And usually you can get glaucoma in these cases in up to 2% of patients without concomitant lens extraction. But it can go up to 15 to 20% if associated with cataract extraction, the pathogenesis of which is not well understood. Why? With partial vitrectomy, you get a high pressure. One hypothesis by Chang is that there is oxidative stress of the trabecular meshwork due to diffusion of oxygen from the vitreous into the anterior chamber. The risk factors of having glaucoma with partial vitrectomy is a pre-existing glaucoma, or eyes with early pressure rise postoperatively are more likely to develop persistent IOP rise. Increased inflammatory response, like patients with neovascularization or pseudoexfoliation, if combined with cataract extraction, if combined with scleral buckling, or if combined with intraoperative scattered photocoagulation. So these are the risk factors that the patient can have high pressure after partial vitrectomy. Medical treatment, aqueous suppressants, laser treatment, SLT may or may not work, CBC conventional or subcyclo, or can even combine it with endocyclo photocoagulation. These are the possible laser treatment. But surgical treatment can be welcomed here. These vitrectomized eyes need special precautions. You can do trap, yes, you can do trap, because the conjunctiva, even if the conjunctiva is opened for the 3 ports of vitrectomy, but still can work and not extensively damaged like in patients with scleral buckling. But keep in mind that you are dealing with a vitrectomized eye. So keep the globe always formed all the time, especially when you excise the scleral block. Avoid excessive filtrations postoperatively. You don't need this patient to have hypotony, so they are high risk with choroidal effusion and high risk with suprachoroidal hemorrhage. In one study, high preoperative IOP and neovascular glaucoma were prognostic factors for failure of TRAP. So if you have risk factors for failure of TRAP, you don't need to do TRAP, like we heard from Dr. Parton shortly. Aqueous shunting devices, still we are dealing with a vitrectomized eye. So better to use a valved implant. So avoid postoperative hypotony. If you are going to use non-valved implant, make sure that you will close the tube thoroughly, and you put a luminal suture, and make sure that you don't have a flow during the early postoperative period. You can do insertion of the tube in the pars plana or in the AC or in the ciliary sulcus, especially if there's corneal pathology. And some glaucoma or retina specialists use the sclerostomy port to insert the tube. This is not welcomed because patients can have severe hypotony. So make a separate entry to do the sclerostomy, to do the insertion of the tube. The one before the last is the intravitreal gas injection. Intravitreal gases like sulfur hexafluoride or perfluorocarbon are used to tamponade the retina and for pneumatic retinopexy, retinal detachment, or can be combined with scleral buckling or BBV. These cases can have angle closure glaucoma, which can be up to 60% according to the concentration of the gas. But recently, the silicone oil study reported that only 6% had an IOP greater than 30 millimeter mercury if we used sulfur hexafluoride 20%. And if we used perfluorocarbon 14%, the IOP will increase in only 18% of cases. So the concentration of the gas is very helpful in these cases to avoid high pressure elevation. What is the mechanism of glaucoma and intravitreal gas injection? As we mentioned, it's angle closure glaucoma. Why? Because the gas expands, and when it expands, push the iris lens diaphragm forward and causing secondary angle closure. And we have to note that these patients, we usually recommend that they stay face down in the early postoperative period. So the gas will go up to the back of the eye and will stay away from the iris lens diaphragm and is not going to push it forward. Also, we recommend for these patients not to travel by air, because traveling by air into high altitudes can increase the expansion of the gas and also induce glaucoma. And one notice also for us, because these patients, it's not wise to do to measure the pressure with shot tonometry or air puff tonometer. It's usually recommended to do applanation tonometer by Goldman or Perkins tonometer. So how can we manage intravitreal gases? Medical therapy is very important, and especially aquasuppressants. But if the pressure is very high, still you can go back to the OR and reduce or release some of the gases outside. This patient is still not pupillary block, so YAG-BI is mostly will not help. Surgical treatment, probably it's better to do aqueous shunting surgery, better than trap, because also the AC is very shallow, may not be welcome the trap. Tube insertion into the pars plana can be helpful, although the pars plana insertion can carry some complication rate, such as choroidal detachment or suprachoroidal hemorrhage or retinal detachment. The last vitreoretinal intervention is the silicone oil injection, and what we have known as silicone oil induced glaucoma. Silicone oil, as we all know, is injected into the vitreous cavity for intraocular tamponade and usually used with PBV for complex retinal detachments, traction retinal detachments, diabetic membranes, such things. IOP elevation can be mild and transient or can be severe and sustained with the silicone oil. And it can be as high as 56% of the cases. What are the risk factors? Whether pre-existing glaucoma or heavy tamponades using combined tamponading with the silicone oil and the gas, or using low viscosity silicone oil because it can emulsify rapidly and the droplets will go into the anterior chamber and block the trabecular meshwork. What is the mechanism? It can have closed angle glaucoma, which may be a pupillary block by the silicone bubble itself, large silicone bubble, especially in aphakic eyes. Inflammation with synechial formation still can block also the pupil, or rubiosis iridis. Open angle glaucoma can happen with the silicone oil if there is migration of the emulsified silicone to the anterior chamber and go inside the trabecular pores, or if we have overfilling with the silicone in aphakic eyes, or idiopathic open angle glaucoma. What can we do to avoid this silicone oil pressure rise? Prophylactic measures, first because the silicone oil is lighter than aqueous, and usually the silicone oil will go floats above the aqueous. And that's why you will find the aqueous is going down, as you can see here. This is going down and the silicone will float up. In aphakic patients or in even pseudophakic patients, if we did peripheral iridotomy inferiorly, there will be a passage of aqueous through this inferior iridotomy, and so we will not have a pupillary block mechanism. Even in patients with phakic eyes, usually the zonular fibers escape of silicone into the anterior chamber. But sometimes we have some defects or weakness in the zonules, and still the silicone can escape anteriorly. What about the treatment of silicone oil glaucoma? What can we do for these patients? Medications are important, and medications are either cycloplegics and topical steroids to reduce the inflammations and reduce synechial formation, and aquasuppressants. Still, we can not use myotics, and prostaglandins here can be used, but still not first choice treatment. Laser treatment in these eyes, if the patient had inferior iridotomy, this inferior iridotomy has about 11 to 30% chance to close. So we can go and open this closed iridotomy by the YAG laser. Even with this YAG laser, the failure rate is high, and sometimes we have to go again and do surgical iridectomy. If this patient has open angle, the pressure rise has open angle, even with some silicone droplets in the angle, one study said that SLT can still work. Now we have the chances. medical treatment fails, does not work. So we have to intervene surgically. What are the surgical interventions? We have three possible scenarios. First, if we are able to remove the silicone oil. Removal of silicone oil, if it is done early, can help control the intraocular pressure. But early removal means redetachment of the retina. And most of the retina specialists will resist removing the silicone oil not before 6 months to even 1 year, because they are afraid about the retina to detach again. So if left for a long time, removal of the silicone oil after long time may not control the intraocular pressure. So removal in this case will be worthless, because already we have progressive synovial angle closure, we have irreversible damage to the trabecular meshwork, and maybe during removal of the silicone oil itself, droplets of silicone will escape to the trabecular meshwork and augment the obstruction. So silicone oil removal is not the solution usually with resistant silicone oil glaucoma. How about the second scenario? Is to combine both silicone oil removal with glaucoma surgery. If the risk of detachment is low, redetachment is low, and the patient has already extensive peripheral anterior synechiae, or there are heavy emulsified droplets in the anterior chamber, in this case, we are able to remove the silicone oil and combine it with a trap mitomycin C, or combine it with a tube. Trap mitomycin C with the silicone oil patients usually has high failure rate. And if looking for doing inferior trap, this actually is obsolete now because of the high incidence of endophthalmitis. So tube shunts are preferred in these cases. Sometimes the obstacle or the debate is that some silicone droplets will escape through the tube into the subconjunctival space and do a lot of inflammatory reactions and irritation. That's why inferiorly inserted tube is preferred, because the silicone droplets will float up and will not go inside the tube in the inferior part of the AC. How about the third scenario? If silicone oil cannot be removed in the presence of intractable glaucoma, which means that patient coming in the first 6 months, intractable glaucoma, and the retina surgeon said no way to remove the silicone. Just do your job. And that happens with most of us actually. In this case, you can do either a non-surgical intervention, which will be cyclocryotherapy, but have high rate of hypotony and visual loss, or conventional or subcyclo transscleral cyclophotocoagulation. This is actually easier and much easier. This patient had a major surgery for the retina and had silicone oil, very high glaucoma, a very high pressure, and needs something to reduce the pressure quickly. So CPC or cyclophotocoagulation can help very well. The subcyclo transscleral cyclophotocoagulation actually can be even more preferred because of the less inflammatory reactions produced in these cases. This is actually the subcyclo photocoagulations or subliminal photocoagulation of Quantel, and it's gaining popularity nowadays. And my personal experience with this machine, it works well. It reduces the pressure, the inflammatory reactions in the patients in the eye after the treatment is much less than the routine cyclophotocoagulation. You can expect that a result to last between 1 to 2 years, and it can be repeated again. Usually you go into the superior and inferior halves, about 8 cycles to have the pressure, and this is recommendations by the company. The second option of doing incisional surgery, and in this case, actually trap is not preferred or not high failure rate, so we use tube shunt surgery. And what we do with these tube shunts in these patients, some precautions. Better to do valved implants, because you don't need much hypotony for these patients. And as we mentioned, put the tube inferior nasally. I usually put tube in this silicone-filled eyes in the inferior nasal quadrant, using Ahmad valve because Ahmad valve is a longer long axis, so it can go posterior. So I prefer to do it in the inferior nasal, not in the inferior temporal. So it will be away from the macula. And in the meantime, you do a short segment inside the eye. So you don't have a long segment, because if silicone came out into the anterior chamber, still will float superiorly, so it will be away from the tube and will not block the tube. Also, as you can see now, what I'm doing, I'm injecting Helon inside the anterior chamber with the same needle I'm doing the track of the for the tube. So I keep the AC filled, not to decompress it, so there will be no chance for silicone to escape anteriorly. And if silicone actually escaped anteriorly, usually it adheres to the outer wall of the silicone tube, because this is the silicone will be attached or attracted to the silicone tube. But I saw a few cases with the silicone bubble adherent to the tube, but not blocking it, and still the implant works well. So these are the scenarios for all the scenarios for the vitreoretinal interventions, and how can we deal with the pressure rise, and how can we treat these patients, and what are the messages that we have to send to our colleagues, the general staff, and also our retina specialists in dealing with the pressure for these eyes. Thank you very much.
Okay, thank you very, very much, Dr. Tarek, for this excellent presentation. Very informative talk with actually a lot of details about different vitreoretinal procedures and the expected outcomes after that. I would like to ask just quite a few questions. Let's say for high myopes, any idea, it's a rather theoretical question, any idea why high myopes would be predisposed to glaucoma with buckling? Because in narrow angle eyes, this is an expected issue with a crowded, short axial length eye. But with very long eyes, already the sclera is already maybe thinned, the eye is long. So why, when we buckle, is there an increased risk of glaucoma? Or are these eyes already glaucomatous beforehand? Any clues to that, sir?
I think for high myopes, first, as you said, this eye high risk also for glaucomas. So these patients could either have glaucoma, or they have hidden type of glaucoma, or are high risk for glaucoma. The second, with the high myope and the large globe, and usually you get a peripheral tears. And to tamponade a peripheral tears in a large globe, usually you go with the scleral buckle anterior. And as I mentioned, if the scleral buckle goes anterior to the equator, there is a high chance to impede the vortex, and also to push the ciliary body anteriorly, so it can close the angle easily.
Okay, so it may be related to the location of the scleral explant. Okay, having mentioned the scleral explant, sir, you've mentioned that we can put a tube in after the glaucoma, after the scleral explant, and we can put a small tube, or we can use the Shocket implant underneath the tube. The question here, sir, have you faced any exposure of the valve reservoir or the tube with the implanted with the scleral explant? Because the conjunctiva in a lot of cases is really scarred, and opening it is apt to cause a lot of buttonholes and problems with that. So have you faced any tube exposures with such operations, sir?
Yes, we have two types of exposures. Either exposure of the tube itself, which is common, or exposure of the implant. Exposure of the implant actually is less common because it's posterior, and usually it's covered by tenons and in the back of the eye, and so exposure of the implant itself is not that common. Although I saw one case before, but exposure of the tube itself, the tube which
You
is
mean the anterior part of the implant
anterior.
entering the eye?
Yes,
Yes.
this is common, and in fact, the key for minimizing, I don't say avoiding completely, but minimizing tube exposure is to cover it. And I saw traditionally many of the surgeons who are doing the tube surgery, tube shunts, just make a superficial scleral flap and go with the tube under the superficial scleral flap, and that's it. This is not giving you a good support to the tube, number one, and is not giving you a good coverage. But put the tube through the full thickness of the sclera without doing any flap from the sclera and get a graft. This graft can be fascia lata, can be pericardial graft, can be whatever, even sclera from a scleral button from a patient who have a BKB or something. You know, the scleral button of donor graft.
So the remaining tire.
Yes, you can use it. But the point is that cover the tube with something. And this will decrease much the exposure. Even if you have a patient with scarred conjunctiva and short conjunctiva, I have a patient with a very scarred conjunctiva that I was not able to close the conjunctiva after I put the tube. And I put the graft on the tube, and I got another amniotic membrane graft. I put it, and it just covered it and sutured to the conjunctiva. And after some time, it was vascularized and everything went fine. So it's very important, and actually it's a message for doing tube shunt surgery. Put the tube inside the sclera, full thickness sclera, and cover the tube. Don't cover it with a partial thickness sclera. Don't cover it with a thin ounce capsule. Cover it with a graft.
There has to be a really tough material over the tube.
Yes,
Sure. Now, again, sticking to the valve, the problem with the valve seems never to end. You've mentioned, sir, that you fill the AC with Helon to avoid escaping of the silicone into the tube. So do you keep that OVD inside the AC, or do you irrigate it, sir?
No, I keep it. Helon first is not like a methyl cellulose or something. Helon is
sodium hyaluronate, you mean, sir?
Yeah, sodium hyaluronate can go through the valve easily.
It does not occlude the valve.
No, Helon does not occlude the valve. Within the first 24 hours, second day you look to the AC, you don't find any Helon. It goes through the valve easily. While if you put methyl cellulose, that really will give you trouble because it stays in the AC for like 3 to 4 days. Pressure is very high, clogging the tube, and it will pass at the end. But you will have about 3 to 4 days of high pressure, and you can do anything.
Systemic acetylcholine. You use IOP lowering therapy for this period, for that spike, sir.
If I have to, if I have to. But I think also Helon is a better tamponade for the
silicone.
AC and for the silicone not to go outside, better than the methyl.
Sure, sir. Okay, now speaking again of the silicone, we've mentioned that for silicone oil-induced glaucoma, we can do a cyclodestructive procedure because it's an intractable, sort of an intractable glaucoma. So what happens if after the cyclodestructive procedure, the silicone oil is removed? Have you faced any, let's say, post-hypotony, post-silicone oil removal hypotony, or even if the silicone oil is removed, it never go into hypotony again?
I don't recall now, but if there is a specific patient, I did for him cyclophotocoagulation, and followed after that, maybe after 4 or 6 months or 1 year, the retina specialist decided to remove the silicone, and this patient had hypotony or phthisis. I don't recall a patient like this, but it's still logic. If the cyclophotocoagulation did reduce the pressure much, while the patient having the silicone inside the eye, I would say don't remove the silicone. Why you are removing the silicone? If the patient is quiet, the pressure is good,
Maybe
or
it's getting
at least
emulsified,
control.
or maybe it's damaging the cornea, sir. Maybe it's injuring the endothelium.
Okay, if another indication, if it is damaging the cornea or if it is emulsified, it means that it has no tamponade effect anymore. So
Okay.
if you removed it, there will be no problem.
Okay.
But if the silicone is still a big bubble tamponading the globe and the pressure is okay, so keep it.
No need to remove it. Sure,
Yeah.
sir. Okay. Now we have one very rather interesting question. It's what about angle surgery in cases of steroid-induced glaucoma and glaucoma after silicone oil removal? Is there a place for an ab-externo trabeculotomy or intra-operative gonio lens and ab-interno goniotomy? I'm sorry. Do you use angle surgery? I mean, in glaucoma after vitreoretinal procedures, or there's no place except for filtering surgery and tubes?
You know what? I have. If a patient has vitrectomy, which means a vitrectomized eye,
Sure, sir.
and his disc is somewhat good, and the pressure elevation, it means that the target pressure in this patient is not that low.
Sure, sir.
I usually do for this patient non-penetrating surgery, like doing viscocanalostomy, for example, because I don't want to expose this patient to hypotony
Sure, sir.
in a vitrectomized eye. So I do a non-penetrating surgery. This patient also can be helped by angle surgery, whatever. If this patient can be like, I don't know if trabeculotomy for these patients can help or not. I haven't tried it in adults.
So do you gonio puncture these non-penetrating cases, sir, or do you don't need the gonio puncture for these cases specifically?
I do, and quite
often.
Quite often, but I will tell you a trick. Actually, I noticed these patients. Unfortunately, we used to use steroids the same as trabeculectomy, and that was a mistake. Post-operatively, we used to give the patient with a viscocanalostomy the same regimen of steroids as trabeculectomy.
Okay.
But I found that still trabecular work is intact. So these patients can be high responders for steroids.
Mm-hmm.
And when I started, after 2 weeks or 3 weeks, the pressure is high, and I used to go for goniopuncture. And then I said to myself, no, I stopped steroids first. And many of these patients returned back. And that's why my goniopunctures decreased a bit because of this.
So it's the modulation of the post-operative steroid use is an issue with the non-penetrating. They don't need that much amount of steroids as the penetrating surgery.
That's how I found it.
And the pathology is not pre-trabecular. The non-penetrating still works.
Mm-hmm.
Okay. Now, thank you very much, Dr. Tarek. And one last question. For these hypotenuse eyes, if they develop serious hypotony and postoperative choroidal effusion, do you refer to the vitreoretinal to drain it, or do you give medical treatment, or do you perform a prophylactic inferior sclerotomy before that?
Okay. If there is hypotenuse choroidal effusion, I usually do medical treatment first. I will give patients cycloplegics, steroids, systemic steroids even. I will give the chance if there is no urgent indications to intervene.
Sure.
If there is indications to intervene, I will go and just drain the choroid. I don't need to go back. The patient go back to the retina specialist.
Okay.
Drainage of the choroid, just a choroidal tab. You go about 8 millimeters behind the limbus
and drain it.
And
simple procedure.
Do simple procedure, but make sure that you have intravenous. Anterior chamber infusion. Yeah, very important. Yeah,
okay,
that's important. Otherwise, and after you finish with the choroidal effusion, I usually do a slit or a snip of sclerostomy.
Sure.
With the Kelly punch. Yeah, and keep it patent. So any drainage can be.
Okay.
But prophylactic sclerostomy, I don't do unless there is a high risk of hypotony.
Unless there is a high risk. Okay. Thank you very, very much, Professor Tarek Eid, for this excellent presentation. And thank you very, very much for having the time and nerves to answer our questions. Thank you very much.
Thank you, Dr.
And
Nader.
we usually, of course, keep our dessert to the end, which is the missed glaucomas, but we would like to apologize for our audience and attendees that we've run out of time. Our talks were obviously so interesting and our questions are even more interesting, so we've run out of time. So for logistic reasons, we've decided to postpone the last talk of Professor Khalil, the missed glaucomas, to the next glaucomatology webinar. And for now, we will have to conclude. But before we